Let us start from question number 12, right? So, a 43-year-old man comes to the emergency department due to a 3-day history of persistent headaches. Uh, the patient has a history of hypertension and his poor medical follow-up. BP is 224 by 115 mm of EG and pulse is 67 per minute. Uh, he appears mildly confused during the physical examination, but no focal neurologic deficits are noted. Fundoscopic examination shows bilateral papilledema. Serum creat is 1.4 milligram per deciliter. An IV medication is initiated that causes arteriolar dilation while also improving renal perfusion and increasing natriuresis. Which of the following agents is most likely being used in this patient? Esmolol, pheneldopham, hydralazine, nitroglycerin, phenylephrine. Pause it and give the answer. So the correct answer for this is pheneldopham. Let us see to the explanation. Okay, so the first thing is the BP is high and it's a hypertensive emergency, right? And the patient is confused, right? And that and with that, there is bilateral papilledema. That means the BP is that much high that it is causing end organ damage, and with that also kidney damage because serum creat is increasing, right? So pheneldopham, because that pheneldopham is used in hypertensive emergency with renal insufficiency, right? Which is in end organ damage, right? And X is short acting dopamine 1 receptors agonist, and it is given is in IV form, right? Okay, why not option A? Asmolol. Asmolol is a cardioselective beta 1 antagonist, right? It would decrease heart rate and contractility, but it is not a vasodilator. Remember, but it is not a vasodilator and not produce renal perfusion, right? Pheneldopham will produce renal perfusion, right? But this is not associated with esmolol. Why not hydralazine? Because hydralazine doesn't dilate renal arterioles, right? And one more thing is it would decrease renal perfusion, not increase, right? And encourage sodium and fluid retention. So this will further increase the BP, right? So this is important. Then why not nitroglycerin? Because nitroglycerin is predominantly venodilator and it is a poor arteriodilator, right? Okay. So what will happen? It will decrease preload. So that's why the when your preload is low, there will be low end-diastolic volume, low stroke volume, and that's why low cardiac output, right? But it do not increase renal perfusion, right? But here this case is presented with uh, you know renal insufficiency. So we would use such type of drug which would increase renal perfusion, right? So nitroglycerin is primarily reducing MI oxygen demand, right? Okay, and that's why it is used in angina. Okay, inginal patients. Okay, phenylephrine, it is alpha adrenergic agonist. It is contraindicated. Why? Because it will increase systemic vascular resistance, right? What will happen? There will be arterial vasoconstriction. So this drug is used for hypertension because it is increasing BP. But is in this case the BP is already high, the BP is already high, so we cannot use this drug. Okay, so this is indicated for hypertension and shock, right? But this is contraindicated in hypertensive emergency. Remember this point. Okay, so what is the difference between hypertensive urgency and hypertensive emergency? In hypertensive urgency, there is no evidence of end organ damage. This is important, right? Where in hypertensive emergency there is severe hypertension with end organ damage. This is important. There is end organ damage, right? Okay. The BP in hypertensive crisis is either equal to or greater than 180 by 120 mm of mercury. Okay. So what are the organs which are uh, damaged in hypertensive emergency? Like in cardiovascular, what will they cause? Angina, MI, right? And aortic dissection. And CNS encephalopathy, since this patient is presented, uh, you know, with confusion. So pointing toward that. So with that, cerebral infarct and hemorrhage, right? And in kidney, acute hypertensive nephrosclerosis, right? In lung, pulmonary edema. In retina, papilledema is in this case is presented, and flame-shaped hemorrhages and exudates, right? Okay, let us quickly go through this. Severe hypertension and secondary end organ damage. Encephalopathy, as I talked about, confusion, presenting with confusion, papilledema and acute kidney injury, elevated creat, hypertensive emergency, aggressive treatment, immediate controlled BP reduction to minimize organ damage. IV agents are preferred in hypertensive emergency due to their rapid action and dose titration ability. Pheneldopham is a short-acting selective peripheral dopamine 1 receptor agonist. I talked about this with little or no effect on alpha or beta adrenergic receptors. It will mechanism is important. It will activate adenylyl cyclase, right? That will raise intracellular cyclic MP, that will cause vasodilation. So vasodilation of most arterial beds, corresponding decrease in SVR, that is corresponding decrease in systemic BP, right? Because it is causing vasodilation. So renal vasodilation, this is important. It is causing renal vasodilation, prominent, right? That leads to increased renal perfusion, increased urine output, and natriuresis. That will cause sodium excretion. What will be the benefit of this is um, it will decrease because there will be sodium excretion, so water elimination, so BP will go down. So pheneldopham especially benefits in patients hypertensive emergency and renal insufficiency, right? Okay, so we talked about this. Why not esmolol? Because esmolol short acting cardiovascular beta 1 selective antagonist, reducing heart rate, myocardial contractility, not a vasodilator, doesn't increase renal perfusion. We talked about all these things. Okay, about hydralazine we talked about. This is important. It is a direct arteriolar vasodilator, right? It's a direct arteriolar vasodilator. Doesn't dilate renal arterioles. We talked about this thing. Decrease renal perfusion. This is also important. So do not use this. It will encourage sodium and fluid retention, right? So it will further increase the BP. So do not use this. Not often used in hypertensive emergency, associated with a reflex tach. This is important. It will cause um, a reflex sympathetic activation that will increase heart rate and contractility. Heart rate and contractility, right? It will increase heart rate and contractility. Nitroglycerin, rapid acting venodilator, talked about this. Decrease preload cardiac output, minimal arterial dilation. I talked about this, that it is a poor uh, uh, arterial dilator. Okay, so um, doesn't improve renal perfusion, right? Primarily used to reduce MI in myocardial oxygen demand in acute coronary syndrome, right? So this is used in angina. Okay, so we talked about phenylephrine, alpha adrenergic agonist, increase SVR, arterial vasoconstriction used in patient with hypertension. We talked about this, contraindicated in hypertensive emergency. Okay, so phenyldopam, selective peripheral uh, D1 receptor, that is dopamine 1 receptor agonist, vasodilation of systemic and renal arterioles, lower lower BP, increasing renal perfusion, urine output, and natriuresis, useful in the treatment of hypertensive emergency. Okay, and in patient with renal insufficiency. Okay, good. Now let us move to the next question. So, a 45-year-old man brought to a rural emergency department due to severe chest pain, sweating, and nausea. The symptoms began suddenly an hour ago. He has no significant medical history. His father died at age 50 after experiencing sudden onset chest pain. The patient smokes a pack of cigarettes daily. Okay, he doesn't take any medications and has no known drug allergies. Examination shows normal heart sounds and breath sounds. ECG shows sinus tach with ST segment elevation and leads to 3 AVF. Okay, medical management for the patient's acute condition is initiated. After initial treatment, the chest pain decreases in intensity and a reperfusion complex ventricular arrhythmia emerges. The arrhythmia is asymptomatic and resolves spontaneously. Which of the following drugs is most likely responsible for rapid reperfusion in this patient? Okay, so pause it and give the answer. So the correct answer for this is, what do you think? It is altiplase, right? Why? Let us see to the explanation. Because uh, what is the important points in this question? First note this. This is the patient, uh, you know, um, uh, which is whose ECG shows sinus tachycardia with ST segment elevation and lead to the AVF. So this is the patient of MI, right? ST elevated MI. Okay, and there is a reperfusion complex ventricular arrhythmia, right? This is emerges. So this is because of altiplase. Why? Because uh, it will degrade fibrin products and will increase d dimer, and those things will lead to reperfusion related ventricular arrhythmia, right? So altiplase, what it will does, it will increase reperfusion related ventricular arrhythmia, and that is associated with the fibrinolytics, right? Like we have altiplase, tenecteplase, streptokinase, urokinase, those things, right? And this is indicated for acute ST elevated MI, right? Indicated for acute ST elevated MI. Okay, apexaban and argatroban, these these are not used in MI, right? And here one important thing is apexaban is in this, XA, apexa XA, so it is a 10A inhibitor, right? So apexaban is a 10A. A is stand for activated 10, factor 10, right? So direct 10A inhibitor it is, right? And while argatroban, that is direct factor 2A inhibitor. Factor 2 is thrombin, right? So it is the inhibitor of that, right? Okay. So the apexaban, that is factor 10 inhibitor, that is used for the treatment and prevention of thromboembolism. You know, that will not lead to the formation of uh, new thrombi, right? So not typically indicated for acute ST elevated MI, right? Okay, this is important. And also the argatroban, that is also not used for ST elevated MI. Remember these two things: argatroban and factor 10A, factor 2A inhibitor and factor 10A inhibitor. These are not indicated for acute ST elevated MI. Okay, so what about um, aspirin? Aspirin and prasugrel, they are also used for what? For acute ST elevated MI. Aspirin and prasugrel. Let's go through their mechanism. Inhibit COX, right? What about aspirin? It will inhibit cyclooxygenase uh, pathway, right? So decrease thromboxane level, right? Okay, that is used in ST elevated MI. Do not cause lysis of existing thrombus. It is not, it will not uh, break down those fibrin clots. So uh, it is not causing this reperfusion complex ventricular arrhythmia, right? And also prasugrel, it is P2Y12A receptor blocker, right? Prasugrel, ticagrelor, we have these drugs, right? And these, what these drugs will cause, they cause irreversible inhibition of platelet aggregation. They do not cause lysis of existing thrombus, just like aspirin. Okay, what about uh, what about about ergotamine? I missed one thing. This is important. It is used for heparin induced thrombocytopenia. This is important. Please do not forget about this. Okay. So what about heparin? Okay, it will potentiate antithrombin which is factor 3, right? It will potentiate that factor, right? And okay, so it is potentiating factor 3 but will decrease factor 2A and 10A, right? It will decrease factor 2A and 10A used in acute ST elevated MI, right? Not cause thrombolysis. So that's why it is not associated with that ventricular arrhythmia, reperfusion complex ventricular arrhythmia, right? Rosuvastatin, which is a statin, right? These, what these drugs will do, they will stabilize atherosclerotic plaque, right? This is their function. Reduce vascular inflammation and promote long-term regression of atherosclerosis. This is important. They are also not causing fibrinolysis. Okay, so this is important. Let me talk about this thing. LT plays. Let me talk about this thing, that which one is used in ST elevated MI, acute ST elevated. Okay, so LT plays is used. These two things are not used. Aspirin is used, heparin is used, prasugrel is used, rosuvastatin is used. Okay, let us see to the explanation. So fibrinolytic pathway, plasminogen is generally converted into plasmin, which is a cutter, right? And that is usually uh, converted by tissue plasminogen activator, TPA, right? And artificially by streptokinase and urokinase and LTplase, reteplase, tenecteplase. Okay, but decreased but decrease this conversion by aminocaproic acid, kappa. Okay, so by aminocaproic acid, this would be decreased. Okay, so what will this plasmin does? It will uh, uh, let's say we have the mechanism, that this is a factor 1, this is the factor 1, that is fibrinogen, right? That would be converted into fibrin clot, and this is done by factor 2a, thrombin, right? So what these plasmin, these cutter, what they will do, they will promote this fibrinogen fibrinogen degradation into fibrinogen degradation products. And also if this fibrin clot is found, this will promote their degradation and will form fibrin split products, for example d dimer. So they will increase this, right? So this is the mechanism of that. Okay, so let us see to the explanation. ST elevated MI, uh, symptomatic improvement, reperfusion related arrhythmia, fibrinolytic, that is thrombolytic therapy, alteplase, indicated in patient with acute ST elevated MI cannot receive PCI, that is percutaneous coronary intervention, in timely manner. Administration of these agents lead to breakdown of fibrin clot and often restoration of myocardial perfusion. In the fibrinolytic pathway, tissue plasminogen activator is released by endothelium. Note this point, right? It is released by endothelium. TPA is released by endothelium. Plasminogen to form plasmin. This is their function. Okay. The breakdown of fibrin clot leads to elevated level of fibrin split products. That is D dimer. We talked about this. Pharmacologic fibrinolytic agents clinically include streptokinase and the recombinant forms of TPA, for example, alteplase, tenecteplase. Okay. Inherently increased bleeding risk and are contraindicated in patients with increased risk of bleeding complications, for example recent hemorrhagic stroke. So do not give these drugs to these patients, right? Okay, why not BNC? Apixaban, we talked about this, direct 10A inhibitor, treatment and prevention of venous thrombolism. We talked about this. Argatroban, why not? Because it's a direct factor 2A, that is thrombin inhibitor, that is used for HIT. Very important, right? Both anticoagulants, fibrinolysis are typically used in the uh, neither cause fibrinolysis not typically used for the treatment of ST elevated MI. Okay, we talked about this. We talked about aspirin. We talked about aspirin, right? uh, COX inhibitor reduce thromboxane level. P2Y12 receptor blocker like clopidogrel, prasugrel, they prevent the binding of ADP to platelets, right? Adenosine diphosphate, right? So we talked about this, that would cause irreversible inhibition of platelet aggregation used together in acute ST elevated MI. They're talking about aspirin and these P2Y12 receptor used together. Okay, do not cause lysis. We talked about this. Do not cause lysis of existing thrombus. Why not option E? Heparin potentiates activity of antithrombin 3. We talked about this. Inhibit factor 2, factor 10A, 2A and 10A. Okay. Used in acute ST elevated MI, prevent further propagation of clot formation, not cause thrombolysis. We talked about this thing. Okay, why not statin? Because they stabilize atherosclerotic plaque. We talked about this. Reduce vascular inflammation, promote long-term regression of atherosclerosis, do not cause thrombolysis. In the fibrinolytic pathway, TPA converts plasminogen to plasmin. Administration of a TPA in a log, for example, alteplase, tenecteplase, streptokinase, fibrinolysis, and can restore myocardial perfusion. ST elevation, myocardial infarction who cannot undergo timely PCI. Those patients who cannot undergo percutaneous coronary intervention, they are given these uh, thrombolytics, right? Okay, so we had already talked about this. These are clopidogrel, prasugrel, and teclopidine, right? P2 whitefill A receptor inhibitor. Then we have phosphodiesterase 3 inhibitor, right? So they contain dipyridamole and silastazole, right? Okay. Then we have um, now remember this. We have GP2B3A receptor, right? And also on this side we have this same receptor. What they does, they will in the mid there will be fibrinogen, right? And these two receptors, these two receptors are GP2B3A receptor, right? They will combine, they will bring close to platelets with one another, right? So this is their function. For their inhibition we will use ipsiximab, right? With that iftifibatide and tirofiban. Okay. Then we have aspirin, that will inhibit COX. We talked about this. What is the function of GP1B receptor? What is the function? The what will happen? They will bring platelets, right, near to the damaged endothelium. Let's say this is the damaged endothelium which have exposed von Willebrand factor, right? What will happen? This exposed von Willebrand factor would be attached to the platelet through GP1B receptor. This is the difference between these two receptors. Remember it again. The GP1B receptor, that is used for attachment with von Willebrand factor, but GP2B3A receptor, that is used for the attachment of two platelets with each other, right? Okay, good. And remember the drugs. Okay, the next question. 23-year-old woman brought to the emergency department with chest wound. She was in her house during severe thunderstorm when a large tree branch fell through a window. The window was shattered and large fragments of the wood and glass struck the patient. She didn't lose consciousness, but her family found her bleeding profusely and rushed her to the hospital. BP is low, 80 by 50 mm of mercury. Pulse is 130 per minute. The patient appears to be in severe distress. Physical examination shows a deep penetrating wound in the fourth intercostal space along the left sternal border. Smaller lacerations are noted across the face and forearms. Which of the following structures most likely injured in this patient? Inferior vena cava, left atrium, left ventricle, pulmonary trunk, and right ventricle. Pause it and give the answer. Okay, so the correct answer for this question is right ventricle. Why? Because right ventricle is the most interior portion of the heart, right? Okay, so I talked about this. Most interior structure of the heart is right ventricle, so that is the reason. Okay, so why not option A, inferior vena cava, right? First thing is uh, inferior vena cava is located at level T8. This thing is important, right? If there is penetrating wound, right, immediately at the back on the right side of the vertebrae, right, on the right side of the vertebrae, that would strike inferior vena cava. Let me draw this thing, because if this is, let's say, let me draw our heart, right? Inferior vena cava, is moving from here. From above we have superior vena cava that would connect it to here, and this would connect it to over here, so this is located on the right side, right? And one more thing, this inferior vena cava is located on the right side, and one more thing is it is located on the back, little bit, in the backward area, not in the front of our chest. Okay, so that's why if there is penetrating wound immediately from the back side, right, so what that would cause, that would cause damage, that would cause strike to inferior vena cava, right? Okay, why not left atrium? Because left atrium is the most posterior portion of the heart. This is let me draw this thing for you for your knowledge. Okay, let's this is heart. This is in the cross manner. This is in the cross manner. The most interior part is the right ventricle. This is important. The most posterior part is the left atrium. Yeah, this is important. Okay, so I talked about this left atrium, posterior portion. Only the auricle of the left ventricle is visible interiorly, to be noted. Okay, left ventricle, left ventricle. It will cover lateral aspect of heart. Left lateral aspect of heart, right? Left lateral aspect of heart, not interior. This is important. Stave wound, fourth intercostal space, slightly medial. Mid clavicular line is important. I have highlighted the whole mid clavicular line. If there is injury to the mid clavicular line in the fourth intercostal space, slightly medial, that would cause striking to the left ventricle, right? This is important. Why not pulmonary trunk? Injury to the second intercostal space, right? Injury to the second intercostal space on the left side of the sternum. I talked about this thing, if let's say this is the heart, let's say heart, the aorta is located on the left side. That would shift to the second intercostal space on the right side. But the pulmonary trunk, this is located on the left side, sorry, on the right side, right? The pulmonary trunk is located on the right side. This will be transferred toward where second intercostal space, but left side. This is important. So that's why. Okay, injury to the second intercostal space on the left side of the sternum would cause injury to the pulmonary trunk, right? You got this point. Okay, so okay, we talked about this. So let's say this is the right ventricle, which is the most interior portion, right, in the fourth intercostal space, right? And with that little bit pleura is located over there. So little bit touch to the pleura, but not the lungs is not involved, right? Lungs are not involved. Okay, so penetrating injury at the left sternal border in the fourth intercostal space, level of the nipple. Fourth intercostal space is at the level of a nipple. Point to be noted, right? Okay, we'll pass through the following layers in order. This is the order. Please note this: skin and subcut, right? Pectoralis major muscle, then external intercostal muscle, internal intercostal muscle, internal thoracic artery and veins, transversus thoracic muscle, parietal pleura, pericardium, and right ventricular myocardium, right? So, the right ventricle, which is the interior surface of the heart, mid and lower left sternal border, right? Okay. The parietal pleura would be injured as well, as I mentioned this thing, right? But the left lung itself would not be punctured, as there is no middle lobe on the left side, as I talked about this thing. The lungs will be preserved, right? Why? They have mentioned the logic, because there is no middle lobe on the left side, right? As we know that lungs, if that is like we have lung, right? If we have lung, my drawing is very okay, but is my drawing is very bad, but it's okay. You would learn it. You are good learner. Okay, so we have on the left side we have two lobes, right? Okay, but on the right side we have three lobes, right? So that's why they are saying there is no middle lobe, right? Okay, so what will happen where I did draw this? Okay, so no middle lobe on the left side. The superior lobe of the left lung is displaced laterally by the cardiac compression. Uh, if let me draw this. Let's say if this is the lung, right? Okay, this would be the superior, superior portion. That would be a little bit uh, moved toward the left side because of the cardiac compression, because of the cardiac impression, right? Because here is cardiac notch, because cardiac, the heart is present over here, right? Okay, so that's why. Okay, so why not option A? We talked about this inferior vena cava, central tendon of the diaphragm at level 8, penetrating wound, pick up the. Okay, we talked about this. Immediate right ventricle, right of the vertebral bodies, strike the inferior vena. Why not left atrium, base of the heart, posterior surface opposite the apex, right? Opposite to the apex. Most of the heart posterior surface. We talked about this. Only the auricle of the left atrium visible anteriorly protruding between the pulmonary trunk and left ventricle. We talked about this. Left ventricle. That would form lateral aspect. We talked about this. Stave wound slightly medial. We talked about this. The mid-clavicular line could strike the left ventricle, but only after passing through the bulk of the left lung. Here this is important. You have to pass through the bulk of the left lung. Then after that you will be able to injure the left ventricle, right? But in order to injure right ventricle, you do not need to cross the bulk of the left lung. You do not need to cross the left lung, right? Why not pulmonary trunk? Pulmonary penetrating injury to the second intercostal space, left sternal border. We talked about this thing. Okay, I think this is enough for today. We will continue from question 14. Okay, thank you.